All right, I'm going to start this with the nursing evaluation. I forgot that slide on the first part of the lecture. So your nursing evaluation would be their hydration status. Is it now balanced? Fluid amounts and feeding tolerance. Are they tolerating the appropriate amount of fluid, and are they feeding? Are they tolerating their feedings? Are there any ongoing fluid losses? Have we resolved vomiting, diarrhea, fever, any pain associated with what was causing the issue? And again, make sure you're evaluating their stool pattern, that it is going back to normal from diarrhea to, again, a normal stool pattern. And depending on the causative agent of the diarrhea, we want to make sure that they aren't having constipation as a result of our treatments. So just make sure that their bowel pattern is back to normal. All right, we're going to talk about our gastroenteritis assessment. Don't forget, when we get to the abdomen, our IPPA format changes. The first thing we do is look at the abdomen, then we take a look, and then we palpate, we take a feel. So your gastroenteritis assessment is diarrhea. It's often watery, green, explosive. It could contain mucus and or blood. Do they have cramping and pain associated with these bouts of diarrhea? Again, what's the level of dehydration? Is it mild, moderate, severe? You'll want to take a look at that table that I discussed, and that will be open on Brightspace. You could see irritability, restlessness, alteration in levels of consciousness. Again, that would be with more severe dehydration. Electrolyte disturbances. Don't forget, the first thing when these kids come in, we're typically we're starting an IV, drawing labs, and starting fluids. You need a baseline of their fluid and electrolyte status before you start giving them all these fluids. Again, it's kind of a 1, 2, 3. We don't wait for the lab results. We'll make adjustments as we get them, but we want to make sure we send them off first. Also be aware we are making sure that metabolic acidosis doesn't kick in. And then again, one of the other things I did want to mention here too is that acute diarrhea can be caused by antibiotic therapy. We've talked about several conditions already that we're throwing the kids on antibiotics for, and again, we can have acute diarrhea with that. The typical cause of gastroenteritis or diarrhea in children is rotavirus. If you look on page 1177, table 41.4, under the first infectious causes of acute diarrhea in kids, the first viral agent is rotavirus. That is pretty common. Our analysis or nursing diagnosis of the problem is infection related to a GI pathogen, fluid volume deficit related to vomiting and or diarrhea, impaired skin integrity because of that diarrhea, and then again, knowledge deficit regarding diagnosis, dietary restriction, treatment. Remember, we talked about anxiety and fear. When these things happen, again, with small children that don't quite understand what's going on, they're pretty fearful when they do have an emesis coming on. And then again, we talked about the patterns of altered parenting, altered family process when you're constantly dealing with a child who is vomiting and having diarrhea. Our first goal is to first and foremost prevent the spread of infection. So we would want standard precautions and strict hand washing, enteric precautions, and that comes from how do we handle linens, how do we handle their undergarments, how do we handle clothes, wash them in hot water and dry them on high heat. How do we handle any of the excretions? Again, we want to handle them with caution. If we have gloves at home, we would want to wear those, wash our hands after. And we would still do those things in the hospital as well, disposing of things appropriately. And then obviously sending specimens. What is the causative agent of that diarrhea, and what can we treat it with? If it's a diapered child, you want to keep that diaper snugly fastened. Kids, when they feel something warm and squishy on their diaper, they tend to put their hands down there to see what's going on. So again, keep their fingers out of their mouth, keep their nails trimmed, no nail biting, no thumb sucking. We already talked about obtaining a stool culture to identify the organism and then administering the proper antibiotic. And then are any of the other family members suffering with any of these signs or symptoms? So let's identify any family members and others at high risk and obtain cultures from them. And don't forget about cleaning toys. Make sure that the parents are cleaning the toys at home. All right, I just came across a note on my notes. So it says infants and young children with acute diarrhea and mild dehydration. How do we manage them? Again, it would be a brief period of NPO, and then an oral rehydration solution would be introduced. Okay, so that's with acute diarrhea and mild dehydration. All right, your next goal is to restore fluid and electrolyte balance. So you're going to administer those IV fluids and electrolytes as ordered. Monitor for appropriate response to therapy. Is the specific gravity coming down because they're not dehydrated? How's their skin turgor? How's their skin color? How's their mucous membranes? What are their vitals doing? How's cap refill? How's their weight? What do I's and O's look like? Oral feedings, the oral rehydration therapy, again, you're thinking Pedialyte or a comparable solution. Are they tolerating that? Can we, and remember, the goal is to resume the normal diet as quickly as possible. Start slow, bland, but with some nutritional content. And then an ongoing assessment of stools, color, amounts, consistency, timing. Okay, and then when we're giving all of these fluids, let's make sure that the fluids are in the right spot. Do we have any third spacing? Is the fluid in the interstitial space or the intervascular space? So make sure we're looking for any fluid overload. All right, our next goal would be to maintain or restore skin integrity, frequent diaper changes, changing bed linens, changing underclothes, keeping the perineal area clean and dry, using a protective barrier on the skin, using A&D if the skin is reddened. Again, constant vigilant care. Frequent diaper changes here. The other intervention we could do for skin integrity is to expose the reddened buttocks to air if possible. Again, you need to see what's going on with the kid. If the periods of the explosive diarrhea have stopped, we can keep the diaper off and do that. That would be an appropriate intervention. Obviously, if they're still having diarrhea, I'm probably not going to go that route. And again, the health teaching, careful review of the diet to be followed at home. Make sure you include in that information diet foods to avoid. I know ATI talks about some foods that they should avoid, and then I believe that's in the textbook too. Make sure their food is being prepared and stored properly. Maybe it isn't rotavirus. Maybe it's something that they got from contaminated food or leaving food out too long or not cooking it thoroughly. So make sure we see what caused it. Again, make sure they know how to instruct them on the disposal of stools at home and what enteric precautions would look like at home, and emphasize the importance of good hygiene, cleaning the area, using that barrier cream or something to protect the bottom or something to help that excoriated skin, keeping the nails short, trimmed, clean, diapers snugly, tightly fastened. Your evaluation or outcome criteria would be that there's no spread of infection, fluid and electrolytes are balanced, no skin breakdown, and parents verbalize understanding of home care. When we're talking about vomiting and diarrhea in kids, if we do any phone triage with them, it's important to note that just because they threw up once or had one episode of diarrhea, they don't need to rush them to the ER. If these episodes are lasting 12 to 24 hours, that's when we want to get intervention. And again, the younger the child, the smaller the time frame that we would want to let this go. Okay, so make sure you're giving some good instruction. All right, let's see. The next thing I want to talk about is appendicitis. The assessment of appendicitis. Well, first off, let's talk about appendicitis. It's usually caused by an obstruction of a lumen, so it is an obstructive disorder. What your assessment looks like, the GI complaints would be right lower quad abdominal pain. We often say that that's McBurney's point, that they have pain at McBurney's point. It's severe and constant. It's aggravated by movement. They have nausea, vomiting, anorexia. The systemic assessment would be that they're lethargic, they're irritable, they're pale, difficulty walking, low-grade fever. If that appendix would perforate or rupture, it usually occurs within 48 hours of the initial complaint of pain. With perforation is where we see that fever higher than 39 degrees Celsius or 102 degrees Fahrenheit. Once that appendix perforates or rupture, they have a feeling of sudden relief of pain, but then that is followed by diffuse pain, rigid abdomen. Their abdomen becomes distended. They start to chill because of that high temp. And again, that's where we see the elevated WBCs. They're elevated to 15 to 20,000. And then with a shift to the left, remember they'll have an increase in those immature band cells. We can also see, look at some diagnostics. We can look at the abdominal x-ray for a diagnostic guide. The issues that we worry about here with appendicitis are pain related to inflammation of the appendix, high risk for fluid volume deficit related to decreased intake and increased output, high risk for injury related to possible perforation, and then with perforation, we worry about infection related to those infectious organisms present within the abdominal cavity. All right, our first issue was pain, so we need to relieve pain. Allow the child to assume a comfortable position, administer analgesics as ordered, and monitor effects. We've talked about pain management in kids, so just refer back to that information. Again, the least, are they being managed with ibuprofen? That's great before we add on an opioid. And again, the more we add on, we need to look at the side effects of what we're adding on. And again, we're getting them ready for surgery. So what does ibuprofen do to the blood? So maybe it's acetaminophen. Just make sure we're looking at pain from every aspect. The other goal is to restore fluid and electrolyte balance. They will be NPO because they're going to surgery. And then we will do IV fluids at the appropriate rate. Again, we will check INO, urine specific gravity. Don't forget the specific gravity reflects the density of the urine. If specific gravity is up, we have dehydration. If specific gravity goes down, it's an indicator of diuresis, that they are putting out a lot. We would want to look at weight. We want to monitor lab data. So your sodium, your potassium. Remember, they're going to surgery. We need to make sure those electrolytes are balanced. And before we give potassium supplementation, we need to make sure that our kidneys are functioning properly. So look at the BUN and creat in addition to the specific gravity. Our other goal is to prevent perforation, so assist with diagnostic procedures to ensure rapid diagnosis, prepare for surgery to ensure rapid treatment, and avoid palpating the abdomen. Anytime anybody comes in with a mass, anything that we can see or feel, it's a good idea never to palpate it. And then you'll see our goal with perforation is to treat the infection and prevent spread of infection. You want to position them in a low Fowler's to localize the infection to prevent that upward spread. So think about when our kids are in that low Fowler's position, if we have those infectious organisms in the abdominal cavity, hopefully they stay there and it doesn't go widespread. We treat it with lots of IV antibiotics, gentamicin, ampicillin, Flagyl, clindamycin. It's usually a cocktail of different antibiotics. Flagyl is a good one with GI issues. It's a good antibiotic to help decontaminate the gut. Coming back from surgery, they could have a drain. They're obviously going to have, maybe if they've done it laparoscopically, they're just going to have some steri strips on the belly. But again, do they have a drain? Do they have an NG tube? And again, the NG tube would be for gastric decompression coming back from surgery. And if they come back with an NG tube, don't forget about their diet. We're probably still going to keep them NPO because of that NG tube and gastric decompression. So how much fluid are we giving them? Make sure we're meeting those fluid requirements, especially if they're NPO. Your evaluation outcome is that discomfort is relieved, fluid and electrolyte balance is restored, perforation is prevented, we got them to surgery, got that appendix removed before it perforated. If it does happen to perforate before we can get them to surgery, the goal of that would be that the infection remains localized to the right lower quad of the abdomen, that it has not gone systemic.